I'm John James. I want to give my thanks to Bill Hewitt for putting this thing together and going to all the trouble to set up a webinar for my presentation. What I want to do is take you on a pathway through what's going on with preventable adverse events in medical care, show us a couple of stories, and give you some perspective. I want to begin by saying that medicine is a very complicated undertaking. Between the medications and all the illnesses that patients can have and the hodgepodge of the way medical records are done in this country, one could argue that you couldn't almost set up a system that is more complicated and convoluted and difficult to manage for physicians and hospitals than what we've done in this country. Given that, I think we can do better, much better than we've been doing. New data from the last few years speaks to massive lethal harm from preventable events in hospitals. I'll describe that in some detail. That is from a study I published in the Journal of Patient Safety in September of 2013. I'm going to tell you a story. It's the third man's story. He's a famous victim of medical error, and I'll show you who that is in a few minutes. I'm going to talk to you about a more complex story, a young athlete's story, and how a panoply of really catastrophic errors led to his death. I want you to understand that these medical errors can be interconnected, but in this particular case, what happened to him is very illustrative of the different kinds of medical errors that can occur. And finally, I'm going to talk about a patient bill of rights. That is the things I think are essential to level the playing field between patients who are ill and a system that is designed more to make money off of their illness than it is to cure their illness in many cases. By way of background, I want to talk about two things here with this slide. I want to talk about the types of medical errors, and for those who are listening, some of these may be new to you. You don't realize that medical errors can occur in this kind of context. And I want to talk about the severity of adverse events that I'm going to talk about. For our purposes, a serious adverse event that's preventable is one type of medical errors. Many medical errors occur that never result in adverse events. But for purposes here, they're pretty much synonymous. So here are the 5 types of medical errors. One is the error of commission. That is, something is done that leads to harm to the patient. It may be the wrong thing that was done. It may be the right thing done wrongly. It may be something left behind in the patient. There are many ways of performing an error of commission. What's less commonly understood is that there's a lot of errors of omission. That is when a patient should have gotten a certain kind of treatment and that treatment was not given to them. Especially, this should be guided by medical guidelines, and often physicians don't follow guidelines for a variety of reasons. Another kind of error is an error of communication, that is between physician and physician or between physician and patient. Now, I've got a little snowflake here and down below. I just want to highlight that a very recent study from Boston's Children's Hospital showed that with better communication between handoffs, the number of medical errors was reduced by about 50%, and this is a very recent study. And what was done there was that those doing the handoff were better trained, there was more careful oversight by senior physicians, and there was an integration. That is, when interns handed off to interns and residents handed off to residents, this was all integrated together rather than kept at a certain level. And so to drop the number of medical errors by almost 50% was remarkable in this case. Another kind of error is the error of context. That typically occurs when a provider, often a physician, doesn't understand the limitations the patient has and kind of sends them on the way, if you will, out of a hospital. And that patient is no way prepared to deal with all the medications they take, or they can't get to where they need to be checked in and followed, and so on. This is fairly common, although there's more attention being given to this these days. Finally, the last kind I want to highlight here is diagnostic errors. This is fairly obvious. It's when the diagnosis is finally made too late to help the patient, or the wrong diagnosis is made from the beginning, or a diagnosis is just totally missed. And I'll talk through some of these in a few minutes in some of my examples. Now, the severity of adverse events here is shown on the right. The least harmful of the severe events, if you will, is prolonged stay in the hospital. The second lower category is permanent harm to the patient. The third is when the patient has to undergo sustaining intervention to keep them alive so that they can be discharged from the hospital alive. And the third, of course, is when the adverse event actually contributes to the death of the patient. The next slide here talks about the database I used for my study in the Journal of Patient Safety. Primarily, the studies involved used the global trigger tool. This is a tool whereby certain triggers in the medical records are searched for by trained nurses or pharmacists or someone of that nature who's used to looking at medical records. And these triggers can be anything from like a stop medication order to a sudden prescription for an antibiotic or something that just triggers the possibility that an adverse event has actually occurred. So what I did here was look at 4 studies. I got these by doing literature search. I searched the Office of Inspector General of the Department of Human Services database and came up with 2 studies, and I found 2 more using the PubMed search. These studies were published between 2008 and 2011, as you can see over here on the right. The time covered by the medical records they looked at is shown here on the left. It's anywhere from January 2002 to August 2008. Now, the time span for the Landrigan study is because he and his colleagues were looking for improvements in the number of medical errors in hospitals in North Carolina over this period from 2002 to 2007. In fact, they were unable to demonstrate that there was an improvement during that time period. And as you can see here, many more medical records were looked at by that team than by the other 3 studies. What's interesting here is shown in the third column, the number of serious adverse events, as I have just defined them in the previous slide, was fairly constant between the studies. It averaged 16%. That's pretty high. That's about 1 in 7, 1 in 6 patients are victims of serious adverse events, not necessarily preventable. Now, the fourth column over shows the estimate of the physicians involved in the studies as to the preventability. This is a very subjective call. You can see the variations from 44% to 63%. Klassen and his team of 9 other experts suggested that all adverse events may be preventable. Now, I got a little bit of feedback on that from a physician who said that's just not true. And yeah, I agree, not absolutely 100% would ever be preventable, but it may approach that, and I think that's what Klassen and his colleagues were really trying to say. The lethal adverse events are shown in the next to the last column, and it's important to note here that even though these studies are small, that they really cluster around a certain value. The lowest is 0.6%. The highest is 1.4%. That's only a variability of a factor of 2. And given the different nature of these studies, that's quite reasonable. The studies of the Office of Inspector General, the one from 2010, is on Medicare patients, that is, older patients, and we would expect more errors to occur in these patients because they're sicker. The study from Klassen was from tertiary care hospitals, that is, ones that are dealing with relatively more complex patients, and we would expect the number of lethal adverse events to be higher here. Landrigan's study was from 10 hospitals selected at random from North Carolina, and one would expect the percentage of lethal adverse events to be lower here. So this all fits into a reasonable pattern, and I think these 4 studies combined certainly can be used to make an estimate of the lethal harm that goes on in this country from adverse medical events. Now, shown here in red, I'm going to use the percent preventable totals down here, 69%, and lethal adverse events, 0.89%. For those of you that aren't used to thinking of decimal percentages, this is about 1%, the 38 deaths out of 4,252. That's just under 1%. All right, this slide shows the estimate for 2007, which was close to the time period when the medical records were looked at from the 4 previous studies. And what I've done here is calculated the preventable lethal harm. It's the total hospitalizations for that year times the lethal adverse events per hospitalization times the percentage of those lethal adverse events that were preventable. So I've used the 2 numbers from the previous slide, and used the estimate of the number of hospitalizations in 2007. That's 34,400,000. And from that, I got an estimate of 211,000 events based on the global trigger tool. Now, a fundamental question: what, if anything, does the global trigger tool miss? And remember, it's used to look at the medical record. Nobody's interviewing anybody involved in what happened. We're looking at the medical record. And there's several things that are very important about what was missed. Errors of omission are going to be missed by this trigger tool. I'll talk a little more about that. Errors not evident in the medical record, that is either omitted or obscured in the medical record for whatever reason, are obviously not going to be detected by the global trigger tool. Finally, errors of diagnosis are not detected either. Now, if I take the first two and show the blue line, I estimate that this at least doubles the number of actual adverse events that occur that are lethal. And then I add 20,000 for diagnostic errors. The estimates here for diagnostic errors are between 40,000 and 80,000 lethal diagnostic errors each year in our country. So 20,000 is a pretty low estimate. No one, to my knowledge, has criticized the factor of 2 I used here, but I want to explain to my listeners how I got that factor. First of all, I want to address the idea that information may be missing from medical records. A study from some time ago now showed that medical errors were much higher when actually observed directly than what is recorded in medical records. Those are medication errors. The quality of medical records was graded a few years ago in a group of cardiology patients by Dunlay and his colleagues, and they found that medical records on average scored 12.5 out of 20 possible points. In his study, those hospitals that had a point average below 10 had 40% higher death rate than those with a score above 15 out of 20. And he was looking for things like a plan for diagnosis and so on, complete list of medications and that sort of thing. In other words, the kind of things one would expect in a well-done medical record. Harmful effective medical errors may not occur for a long time after discharge. There may be something done in the hospital that actually would not have an effect for many years on the patient. And so that may not show up in the medical records at all. Data altering and deletions in the face of an adverse event are not presumed to be uncommon. The IOM mentioned this in their report from 2004 called Patient Safety, Achieving a New Standard of Care. A very important study by Joel Weissman was published a few years ago in which he asked patients 6 to 12 months after they were discharged if they knew of any serious adverse events that happened to them as a result of their hospitalization. They could recall 3 times more serious adverse events than were actually evident to physicians who reviewed the medical records of these patients. And the observations of the patients were confirmed by physicians on Weissman's team. This is a very important finding and suggests that a lot of things are left out of medical records or obscured. Finally, almost 2/3 of cardiologists admit in a national survey that they had firsthand knowledge of a serious medical error and had refused to report it to anyone in authority. In my opinion, it's unlikely that those events actually showed up in the medical record if they're not going to be reported to anyone in authority. And this is a study from Eric Campbell and his colleagues in the Annals of Internal Medicine in 2007. So the medical records themselves are not what you would call the gold standard of what actually happened to a patient. They are the physician's take on what happened. Now, there are also things that are not detected by the global trigger tool, whether they're in the record or not. Errors of omission. A few years ago, up till 2000, at least 100,000 people were dying every year from failure to treat cardiac problems with beta blockers. Beta blockers were shown to be effective in 1982, but it took a very long time for the cardiology community to start using this across the board for patients that were undergoing heart failure. In 2007, they finally got it right. This was actually taken off as a standard because finally, after 25 years, virtually everybody that needed beta blockers was getting them. Errors of context. The global trigger tool is not smart enough to know the context of the patient, so there's no way it can pick up an error related to context. And finally, errors of communication. A trigger tool is unlikely to detect these unless they lead to some other kind of medical error, such as an error of commission. But in and of themselves, errors of communication are going to be unseen by the global trigger tool. Any good presentation of medical errors and the harm that's caused must have stories. All the numbers, all the statistics, they're just dry numbers, and they really don't impact people. I worked for 25 years, 24 years actually, at NASA. I'm just retired from there. And what I've got to say in all of this is not directly related to my job there, but I was rather shocked to discover, as I did my patient safety work, that the third man to walk on the moon, Pete Conrad, was a victim of medical error. This shows Pete getting off of the lander on the moon. As I said, the third guy to step on the moon. What happened was, many years after he visited the moon, he was in a motorcycle accident in California. He was conscious when the medics picked him up, but when he got to the hospital, they failed to recognize that he had serious internal bleeding, and he died. I invite you to search the web for some videos of Ms. Conrad's story, Nancy Conrad. She became a patient safety advocate, and you can read here her take on this. She was really broken up by his death. Obviously, she clearly cared about this man a lot. But my point in saying this is that it's not just about the individual killed by medical error. It's about the people that cared about that individual. So it affects many more than just one individual. Other famous people that have recently died as a result of medical errors, John Murtha, a congressman, had surgery. I believe it was gallbladder surgery. Apparently it was colon. His colon was nicked during the surgery, but it wasn't realized at the time. He was sent home from the hospital, and some days later it was clear that he was not doing well. And by the time they got him back to the hospital and figured out what was going on, it was too late to save his life. Michael Jackson was a victim of Conrad Murray, MD, a cardiologist who was Jackson's personal physician and gave him too much propofol, which should never be given to any patient outside a hospital. It's being given to Jackson in a mansion that he had rented, and he never woke up. And that's a pretty well-known story. By the way, his physician is trying to get his license back in the state of Texas. Finally, Anna Nicole Smith was a victim of medical errors because she had so many physicians that liked treating her and giving her whatever she wanted. And she got this combination of drugs that simply killed her because of their interactions and because of overdoses. And the blame there has to go to the doctors who prescribed these medications to her. Now I want to talk about a young athlete, and this particular set of medical records I had a chance to look at involved a lot of people, and I know about this young man. He had parents. He had a sister who was a couple of years younger than him. He was almost 20 years old. He had a 10-year-old little brother. He had grandparents and cousins. All of these people were affected by the adverse events that happened to this young man. So what happened? This young man was a runner. He'd run through summers along the Gulf Coast where it's very hot. You can see in this picture the front of his T-shirt is loaded with sweat from running in relatively hot conditions where the humidity is very high. He went back to college and he was running and collapsed while running in Waco, Texas. He was taken by ambulance to a hospital. He actually self-recovered. He was evaluated there for 5 days by a team of cardiologists. They gave him a clean bill of health 5 days after his discharge from the hospital. He returned to running gradually. It had to be gradual because he had some growing wounds from where they had done a cardiac cath and electrophysiology test, both highly invasive tests that it turns out he didn't need. And 18 days later, he collapsed and died while running. The question is, was this young man's death preventable or not? Were there errors of omission, commission, diagnosis, communication, or context? Let's have a look at his medical records a little bit. Well, his cardiologist failed to apply a national medical guideline for potassium replacement in a patient with cardiac arrhythmias, which this young man had after his initial collapse. He actually had 3 of them, and he had a serum potassium well below the 4.0 limit that was published for this medical guideline. Now, in 2000, it was common knowledge among those that thought at all in the medical community that potassium, low potassium particularly, is associated with cardiac arrhythmias. But the guideline published by the National Council for Potassium in Clinical Practice in 2000 in the Archives of Internal Medicine, the gold standard internal medicine journal in the world, 2 years before he died in 2002. And yet it seems like his cardiologist did not know this guideline that was very important to saving his life. So that's an error of omission. They didn't give him potassium replacement, which is very simple to do. They failed to make an easy diagnosis of acquired long QT syndrome. The reason he acquired long QT was because his potassium was depleted. It's well known that the QT interval is lengthened if the potassium goes too low. And there's specific diagnostic criteria called the Schwartz criteria that were published in about the mid-'80s first. They reached their final criteria in 1993, and in 2002 they were actually published in the American Heart Journal. I'll show you that in a second. Amazingly, the consultants that were called in from Austin seemed to be unaware of how to deal with QT. The consultant stated in the medical records that this young man's QT interval was upper normal. In fact, you can't even decide normality in a QT interval until it's corrected for the heart rate. That's called the corrected QT interval. He wrote that the corrected QT interval is 490 milliseconds. That is quite abnormal. So that diagnosis was missed. I'll show you a little more detail in a minute. Finally, there was a failure in duty to warn, and you don't have to know any cardiology to sort this one out. His team of cardiologists knew the patient shouldn't be running. They hadn't figured out what was wrong with him despite the invasive tests. When you totally miss a potassium depletion, it's no wonder you don't miss about everything else. Anyway, they failed to communicate this after his final medical test. They told him, and the medical record shows this, when he was so loaded with a high dose of the drug Versed that he could never have remembered what he was told. Versed a great drug. It makes you forget what happened to you. Dentists use it all the time. His written discharge instructions were don't drive for 24 hours. No mention of the caution against running. Finally, his cardiologist failed to communicate to the physician in training, in family medicine, by the way, and he saw this doctor 5 days after his discharge, that running would be dangerous to him. There's no evidence in her record of that visit that she was aware that she should warn him not to run again. And so she gave him a clean bill of health. And as you know from the previous slide, 18 days later, he died while running. Now, what about missing the diagnosis? Here's the Schwartz criteria graphically. It's a point system. 1 point is low probability, 2.5 intermediate, 4 high. This young man actually had 5.5 points on this scale. To miss this diagnosis is just unconscionable. Here is Dr. Schwartz's take on this. This is from a textbook called Cardiac Electrophysiology from 2000. The unusual combination of an often lethal disease for which effective therapies exist and of a rather elementary diagnosis makes inexcusable the existence of undiagnosed and therefore untreated patients with long QT syndrome. These criteria were reiterated about 8 months before the events I just described unfolded in something called Curriculum in Cardiology in the American Heart Journal. A curriculum in cardiology is listed as something the practicing clinical cardiologist must know to be effective in the treatment of their patients. And these particular cardiologists totally failed this young man. All right, now I want to go on. I've told 2 stories, the third man's story, the young runner story. Now, what's to do about it? Here's what I think. Americans shall have safe health care that is just, transparent, accountable, and evidence-based. That's all we as patients want. Just means that The quality of your care is not highly dependent on how wealthy you are. If you're poor, you have access to reasonable care. If you're rich, you have access to reasonable care. Transparent. That means you as the patient know everything you need to know about making a choice about where to get treated and by which physician. Accountable means that when errors occur, and they're bound to occur because we've got humans involved here, the system is held accountable, and those who are members of the system involved are held accountable. And finally, it's evidence-based. That means that the way patients are treated is based on scientific evidence published in guidelines from cognizant groups that are not biased. Some medical guidelines are biased, and those have to be looked at differently, but there's plenty of well-formed evidence-based guidelines that say how people with certain conditions need to be treated, and those are often not followed in hospital care. So let's look at some of the detailed elements of this Bill of Rights. Every day while you're hospitalized, every day, patient is offered their medical records, and they're shown how to make entries in those medical records. If the patient is not cognizant or is too sick to do this, their advocate gets to do this. What we know from things I've said already, medical records are often missing critical data, or it's typically very poor quality data. Medical records are missing information about serious medical errors once everything's said and done, if an adverse event occurs, for example. And as I said, 2/3 of cardiologists have firsthand knowledge of a serious medical error and didn't report it to anyone in authority. There's a lot of things going on in healthcare that are not nice. Evidence-based care. Your diagnosis and treatment shall be according to guidelines. The patient shall be fully informed and give their consent when the care should deviate from these guidelines. It's very important. Otherwise, you basically got human experimentation without the patient's consent. Dangerous and unnecessary procedures are often performed on patients against medical guidelines and without their understanding of what's going on. Physicians, and especially cardiologists, are known to be very slow to adopt evidence-based, patient-centered guidelines. And I use the example of the slowness of the adoption of beta blockers for use in patients with heart failure. Drugs prescribed off-label. By off-label, I mean here, drugs that are prescribed to patients who are outside the age band of the population that was used to test the drug. That typically would be very young patients or very old patients. Drugs are typically tested on middle-aged people. Off-label also means for a medical condition that was not evaluated for the FDA to approve the drug for any use. Now, what most people don't know is a drug approved for anyone use at all can be prescribed by a doctor for any other use he pleases. And that puts the patient at, I think, a higher risk because it is an off-label prescription. Okay, doctors need to be able to do that. That's okay with me, but they have to get the patient's permission to receive a prescription for an off-label drug, and they need to understand the risks associated with that. What we know is from the media and other things, overprescribing of antibiotics has led to a crisis in this country. Off-label prescriptions waste money, expose patients to all sorts of unnecessary risks. This is an area for real reform. Physician competency. You need to know how good your doctor is. You need to know medical malpractice information, his board certification status, his maintenance of certification, and so on. A study found, and this is Campbell's study from 2007, that 3/4 of cardiologists had not been evaluated for competency in the last 3 years. Nationwide study. That's pretty scary. Information turns over pretty quickly in fields like cardiology. And if the competency hasn't been assessed in 3 years, that's pretty scary. In 2005, about half of all board-certified cardiologists were certified for life. Now, those certified for life could voluntarily participate in maintenance of certification. That means demonstrate to their medical board that they're still competent in their discipline. About 2% of those chose to do that, and about half of those actually passed maintenance of certification. So if your cardiologist was board certified before 1990s, board certified for life, and you better be careful because They don't have to maintain current knowledge to continue to call themselves board certified. Continuing medical education for physicians doesn't do a very good job of ensuring competency. 6 states, as of 2012 at least, had no requirement for any continuing education of medical doctors in their state. New York State's probably the most populous state among those 6. In Texas, continuing medical education is verified by the medical board on only 1% of doctors each year. Now, that's pretty scary. If you were flying on a commercial jet and you knew that the pilot was evaluated for competency at the 1% level each year, that is, most 99% are evaluated each year, would you be flying in airplanes? I don't think so. So why do doctors get by with this low requirement? It has to do with money in a stingy state, but that's another issue. All right. Costs shall be known to the patient before they agree to surgery. Many of you have probably seen remarkable articles in Time magazine and others showing the diversity in costs of medical treatment. I think there was one from California a few years ago where the cost of an appendectomy was anywhere from $1,800 to $180,000 in hospitals. This is ridiculous. You can't go on like this. If you have an elective procedure, you know the complete cost across the board before you agree to it. In emergency procedures, somebody needs to look after the patient and make sure they're not gouged by the healthcare system. What we do know is the cost of procedures in the U.S. are far higher than other developed countries. The majority of bankruptcies in the U.S. are due to medical bills that cannot be paid, and the cost per person for healthcare is at least twice that in other developed countries. This is silly. Why can every other developed country in the world do it better than us? Well, the answer to that is money. Adverse events. Okay, no matter what we do, a few adverse events are going to occur, and this doesn't mean they're preventable. It only means that they occurred. Something went wrong, apparently, and somebody was harmed or died, and they shouldn't have. The hospital and the doctors involved have an obligation to engage the patient or the patient's survivors in the analysis of what went on with the medical error and sort out the issues. What we know is that 1/3 of hospitalized patients are harmed during their stay in the hospital, and about half of those are seriously harmed, as I've shown earlier in the studies I used. The vast majority of errors are kept secret from the patient or their survivors. I had a conversation with a gentleman a few years ago who was then the president of the American Board of Medical Specialties. That is the board over all the major medical specialties in the country. I don't get called back very often from an important person, but he called me back. And we had a little conversation, and I asked him, how often do patients really know about a medical error that's occurred to them? He said it was 1% of the time. I tried to argue with him. I said, I think from what I've seen in medical journals, it's more like 30%. He said, no way, it's 1%. They seldom know about the medical errors that happen. So then I asked him, well, what are patients supposed to do about it? He said, nothing is really going to change until patients raise a ruckus. Think about that if you're listening to this. Duty to warn. Patients receive enough information to choose a hospital based on its infection rate and other adverse events that occur there. And at discharge from that, they get written warnings of any lifestyle risks to their health. And I think back to the young man, the runner, who died because nobody really told him, except when he was loaded with a drug, that he should not be running. Most hospitals keep their infection rates secret. That's starting to change as we force hospitals to report their infection rates. Of course, most of this is self-reporting, and that's never very reliable. Risk of harm can vary greatly from hospital to hospital. Some of the cardiac procedures have a 5-fold variation in risk from one hospital to the next. I think you'd like to know that if you were going to have a coronary artery bypass surgery. Inadequate warnings are not uncommon at discharge, and that's been shown in scientific literature and so on. Informed consent. This is really a pet peeve of mine. I think physicians and nurses and those who are treating patients really have an ethical obligation to give a patient enough information to make an informed consent, and they aren't really doing that now across the board. One study showed that only a tenth of the time do patients receive enough information to make an informed decision about their care. Cancer patients particularly don't get the information they need, and this has been made clear in major publications. Here's one, Delivering High-Quality Cancer Care, Charting a New Course for a System in Crisis. That's from the Institute of Medicine, the IOM, in 2013. Now, do you want to receive cancer treatment from a system in crisis? There's something going on here, and there's something wrong. If you want a good read, I would suggest a book by Otis Brawley, MD. He's an oncologist, and the title of his book is How We Do Harm, and he talks about the mindset of many cancer doctors in terms of what they offer their patients, and he speaks to the fact that most cancer patients don't get the information they need to make an informed decision. And I've already said the last one here, coronary artery bypass surgery varies fivefold between hospitals. Wouldn't you like to know that before you decide to have one of these at a specific hospital? Patient's feedback sought. This is the customer's feedback. This is really important. You as the patient, assuming you survive your hospital stay, or your advocate if you didn't, is asked to report on the quality of care they receive there. And a lot of these things are going to be subjective, but there's a number of studies running around these days that show that patients really can give a new and fresh perspective on the quality of the care they got while they were hospitalized. They don't know all the medical details and so on, but their perspective is very important. There's some efforts by the Agency for Healthcare Quality and Research to get this going. In my opinion, they're going too slow. This isn't that complicated. You get the system in place. And hospitals, if they know their patients, their customers, are going to give feedback, they're going to be a lot more careful about the kind of care they give you. Right now, it's kind of hit and miss in many places. You have a right to have an advocate present while you're hospitalized. Many hospitalized patients are very ill. They can't look after themselves. If they can pay or somehow have an advocate present, it's very important to their care. As I've shown, communication errors are common in hospitals. And there's a complex situation here, and that's not surprising. Studies show that the patient advocate is the primary integrator of medical care. It's not any of the nurses. It's not any of the doctors. It's the patient advocate. If you want to read an interesting book, Jody Gilhofer wrote High Performance Healthcare a few years ago. She had looked at Southwest Airlines and asked, why do they seem to be doing so much better than the other airlines? And she used the same approach to look at hospitals. And somewhat to her surprise, I would believe, she found that the only real integrator of care in a hospital is the patient advocate. It's not the hospitalist, it's not the attending physician, it's not any of the nurses, it's the patient advocate. Patient advocates have spared patients from harm more than a few times. Finally, I just want to conclude with 3 points. The current medical industry performs in what I would kindly say a suboptimal way. They can do a lot better. Errors in the system in hospitals, not outpatient errors, just system in the hospital, contribute to 1/6 of all deaths in the U.S. each year. 440,000 is approximately 1/6 of about the 2.4 million people that die in this country every year. And 440,000 is just under the number of deaths from cardiac problems and from cancer. It is a serious problem that needs more attention. Iatrogenic deaths, that is those caused in a hospital by the care, are accompanied by severe collateral damage to the victim's family, friends, and those people that cared about them. I've illustrated that with a couple of stories, and I think that's obvious unless you're just harming hermits in these events. Finally, I believe a national enforced patient bill of rights is essential to level the playing field between the patient, who is often ill, and the providers and caregivers who are functioning in their system. Often that system is designed to make money, and if the patient gets suboptimal care, there's very little accountability. For example, I might mention the young man, and I've showed 4 major errors in his care. That was deemed to meet the standard of care. in my state of Texas. Uh, the reality is the concept of standard of care is very silly because a doctor just says, this looks like the standard of care to me. There's no tie to guidelines, tied to effective care, and so on. So we patients and prospective patients, and that's all of us, sooner or later they're going to get us, need to have a level playing field, and we need to have rights. And this is no different than workers who can be victimized by companies, take advantage of them, by minorities, by people that are aged or young. They have to have rights so that a system cannot exploit them. And I believe in many cases, patients are exploited by the healthcare industry and hospitals. And that's
thing that I still find very interesting is on medical records. How do other countries maintain their medical records for patients?
actually, Bill, that's a very interesting question. In the U.S., we're beginning to slowly transition to electronic medical records. I think that's mandated in the Affordable Care Act. Other developed countries have had these for quite a few years. We are far behind in implementation of electronic records. The decision, and I think it was a wrong one, under the Bush administration was to let the provision of the formats for the records be competed. And so we have a hodgepodge of electronic medical record systems across the country. And I think that really impedes the ability of doctors to do their job efficiently. Because, you know, if they, for example, you're in an emergency room and here comes a patient in, and they're probably not going to have their medical record anyway in any form. But if they do, it may be in a system that you're not familiar with because it's system XYZ and you've been used to using system ABC. To me, there's no excuse for not having a national medical record system that is organized in the same way, that everything is found in the same places it needs to, and from which the key facets are extracted so that a physician can read an abstract of the patient's medications, of their known conditions, and so on, and find out very quickly what's going on with this person from their medical records. But, and I hate to include myself in this too, but if I were drug off to the emergency room right now, I don't have a copy of my medical records. It's at home. It's in a paper folder somewhere. I would make everybody have access to an electronic copy of their medical records, whether it's a stick they carry with them or whatever. But it's so important. And I should say too this: in France, everybody has a little card. In Taiwan's this way too. It's like a credit card. And on that card is a little gold-plated chip that has their medical records in it. So that all they have to do is flip this card out, and or if they're collapsed somewhere, the EMTs find the card and they can find out the medical history of this patient, which could be very important to optimizing their care. So we have a lot of work to do in terms of getting medical records right in the United States.
Is there any study on the medical records per se that you could look at that compares one country against another, or?
I don't know any offhand.
What I'm thinking is that it would seem like a private company could offer patients to provide that system if they have access to the information.
Yes, they could. And there are services out there now. If you want to put your medical records on a server somewhere, you can do that. If you want to put them on a stick, obviously you can do that because you're in control of everything. Of course, there's issues with the HIPAA thing, you know, the security and all that. And some people apparently really care about anybody else looking at their medical records. I could care less if the whole world sees my medical records. I don't care.
Yeah.
So, but there are services out there that provide that. But there again, there's not one common standard for the way you lay out medical records in the United States, and that's a huge mistake on the part of the national system, if you will.
Yes. But certainly, I think portability is a very big issue here because people travel a lot. And that must be a big problem, for example, with the transportation industry where you have truck drivers going across the country and they have accidents all the time. And obviously, when that patient or the truck driver becomes a patient, they would have a difficult time trying to find out what his medical condition is.
Absolutely. You're let's say the seminal event that really disables you, a heart attack or some appendicitis, something comes on acutely in you're traveling somewhere. You're visiting relatives way off somewhere from your home state. You know, and they don't know a thing about you when you come into the emergency room. And it would be so valuable to quickly get a look at your medical records and find out who you are as a patient and tailor your treatment that way. But we can't do that now in this country. And a lot of doctors are very unhappy. We're going to keep fiddling around with this silly system we've got, and we're going to lose a lot of good doctors because they just get so fed up hunting for stuff and filling out insurance forms. Insurance forms should be standardized as well. We don't pay people to go to medical school or get them to pay hundreds of thousands of dollars to fill out a bunch of forms for the rest of their career. We want their physician knowledge. Yeah, so there's some fixing needs to be done.
Yeah. The point you raised on one of the issues, let's see, I think it was F, where the medical error resulted in an extended hospital stay.
Yes.
I assume the patient's going to have to pay extra is what it results in. And,
yes.
And if they don't know that a medical error was involved, then obviously the patient would pay for it with a smile. But if they were realized that a medical error was involved, and at this point nobody knows. Nobody knows.
Well, yeah, absolutely. And in the end, for most of us, our insurance company will pay, and they don't necessarily know what's going on. I'll give you an example that happened to me in 2008. I had a radical prostatectomy at a hospital that touts itself as one of the best in the country in Houston. I won't say which one. I had the surgery, and they insert a Foley catheter, which goes into your urinary bladder. It's supposed to drain the urine. And a ball gets inflated in your urinary bladder to keep it in there so that the urine can drain. And many of us that are my age have had one of these things in at some time or other. Somewhere along the line, somebody forgot to inflate the thing. So a few hours after my surgery, it just fell out. Oh. And so they had to jam another one back in there. And that put me at risk because the surgery was done right where they had to jam it past. There's a higher risk of infection, a risk of disrupting the surgical site. Fortunately, that did not happen, but I got an extra day stay in the hospital because it had to be reinserted. Now, my insurance company paid for that without any question, but it was a mistake on the part of the hospital. And I don't know how they made the mistake. I don't think they had checklists for the surgery, and so nobody knew that they were the one in charge of inflating the Foley catheter.
That's almost $1,000 a day if you're in the hospital.
Well, yeah, and if you know where to look for medical errors, you can find them. I can tell you that nobody in my family has been treated at a hospital without experiencing an important medical error.
Hmm.
You got to know where to look for them, but if you know where to look for them,
Yeah.
they're there.
Another important issue you brought up is the patient advocate, and it, it sounds like a new occupation. But do you have any information on how do you train a patient advocate? Is that sounds like it's new too? And
Well,
and
yes, it is, but there's been patient advocates for many years. They're family members, and we go in and we do the best we can. We're not trained, but we do the best we can for a loved one that's in the hospital. There are, as you well know, formal training courses for patient advocates for hospitals, and they vary from place to place. It is a relatively new profession, but I know of people who have hired a patient advocate, for example, for their elderly father, when they can't be present in a hospital to look after their father. And these people make pretty good money, and it's a tough thing to do. You're there 24/7, perhaps, and you're looking after a lot of things, but you are there solely to look after that patient. And of course, the right kind of training is important. You need to know who's who in the hospital, but I would bet you just by having a professional advocate present for a patient is going to get them better care, because the staff and the doctors know who that is, and if they know that person is wise and on top of things, they're gonna be at the top of their game.
yes, that it seems critical to me because I'm familiar with some of the studies that have been done in the past, and there are two organizations, I guess, that are that are doing research in that area. And one of them is IHI, or Institute of Healthcare Improvement, and they had two campaigns they put on in 2006, 2008, and I was familiar with the 100,000 Lives campaign uh, that they did from 2004 to 2006. And they had the information on 37 million. This is according to their information. Dr. Donald M. Berwick was the one that actually organized that campaign, and he did sign up 3,000 hospitals. I think it was a little bit more than that. And all the hospitals in Indiana were a part of that. And that's true in most states to get that number. And they had looked at the situation from the standpoint that you mentioned earlier, where they just looked at the medical records and they could see all these errors. And the result was the reason they named it 100,000 Lives campaign was based on the original IOM study that they killed 90,000 people a year by medical error, which is astounding. But they actually did save with their program, according to them, just from the medical record review, that they saved 122,000 over an 18-month period, which correlates with the IOM study that was done by Dr. Lucian Leap, I believe, and his staff. And they they came out with statistics that out of 37 million patients records they looked at, 15 million had medical errors that they could determine just from the medical records. And that's a 40% harm rate, because they were going on, they want to see what the harm rate is. And then they followed that up with a second campaign called the 5 Million Lives campaign, which they intended to reduce the harm rate by 30%, because when you look at 5 million lives, that represented 30% of the 15 million that they found the problem with the medical records. Now with your study, that says that would have been double that. Basically, is what I see from the data. Is that, am I doing the correct math here? Or?
You're basically right. And what they wouldn't have looked at, and why my number is higher than many others, is because I looked at errors of omission and diagnostic errors and errors of context that are very difficult to detect from the records. But we know they exist. There have been many reports in major medical journals about these kind of medical errors. And what you see is it's kind of a silly thing going on here. If the IOM estimated that up to 98,000 are killed each year, and then Don Berwick and his guys come along and say, well, they've saved 122,000 a year. Wait a minute. That means all the lethal harm in hospitals should be gone, and then some. But we know it isn't.
Right.
And so there's a lot of, let's say, subjectivity in the way medical errors are assessed. I'll defend my study against anybody's, and I really would like to see the IOM come in and look at my study and see what they think of it. I've only had one person take a pot shot at it, and I deflected him pretty quickly. He was an MD. So, you know, we need to get probably a standard system to assess these. But, of course, the first thing is truth in medical records.
Yes.
And I will say this. In the event of an adverse event, if the medical records are falsified, that is legally equivalent to tampering with evidence. And I think it's subject to criminal penalty. That's my opinion.
Yes. Now, the patient's Bill of Rights, I can see how you're addressing both the medical record documentation of medical errors that the global trigger tool addresses, or that's what they're looking at, because that was developed from IHI's campaign in 2006 and 2008, and your study has identified that they only look at about half the problem, and the all the studies, I believe, maybe I'm an error here, but I believe all the studies from 1998 on up to date, with the exception of your study, dealt or used the global trigger tool. Well, you used the global trigger tool too, but they use the global trigger tool only. Is that correct?
Well, primarily, the four studies I cited are the only ones I'm aware of that use the global trigger tool primarily. And they, in some cases, used ancillary, like administrative records and so on. But for the most part, those didn't show much and are not a direct look at the medical records. It gets really complicated to try to sort all this out. If somebody really wants to dig into it, they can look at my article where I deal with these other approaches. But the global trigger tool, to the extent there is any gold standard, is the gold standard for hunting up these adverse events and then deciding which may or may not be preventable and how much harm is caused. But it didn't really even get started until 2000 or so, and it's kind of evolved over the years into what it is now. And there are different forms of this. For example, there's a global trigger tool for pediatric medical records and so on. So there's not a single form that is used on all medical records, for example. Does that address your question? I'm not sure it did. But
yes, I guess maybe I'm thinking there's a tool missing here, because the global trigger tool catches the medical errors in the medical records. And it depends on the medical records being correct, of course, but uh, that only speaks to half of the problem, and that is how would you're depending on the patient's bill of rights to catch the rest or all of it, basically. And
Well, I
the the only way you're going to do that is with an advocate, because there's no way to catch those errors if they're not entirely dependent on the medical record. In other words, half the medical errors occur outside the medical records themselves.
a lot do. In Joel Weissman's study, a number of the serious adverse events that occurred that were not in the medical records actually occurred after discharge, but a number of them occurred during hospitalization and were not recorded in the medical records, at least not in a way that a reviewing physician could find them. It's a messy business. How do you pick up errors of omission?
Right.
Who decides what should have been done and wasn't? Who decides this runner needed potassium replacement and didn't get it? Well, there's a guideline out there that's very clear and explicit, but you got to know the guideline is there. And if you don't, you're not going to pick it up.
Yep. That's for sure.
It's not easy.
Well, that's my last question.
Okay, well, we went for about an hour, and Bill, I appreciate your help in all this, and I hope we get to meet one day.
Well, I would like to, sure. I think this is a very valuable thing we're doing here, getting discussion going on this problem. And your study is so new, of course, it hasn't been fully embraced by everyone yet. But I think that it's very, very important, because this is the only way that you're going to get a patient movement started toward having a patient advocate, toward having good medical records, or something like the French or the Taiwanese do.
Mm-hmm.
Yeah, those things have to come about, or we're not going to have good health care. And right now, according to all statistics that I see, we don't rank very high.
No, we don't rank very high at all. The only thing we're highest in is the cost per patient.
Yeah.
In terms of life expectancy, in terms of infant mortality, in terms of maternal mortality, we are about 40th in the world.
Yeah.
It's a shame.
It is.
And I don't know what the people have to do to lay this at the foot of Congress and the president and say this has got to stop.
Well,
but no one seems to do that.
I think you need programs like this where you get a patient movement started, and your Patient Safety America. Are you going to post the patient's Bill of Rights on that website?
Actually, it is posted.
Okay.
It is posted on that site. Although I've got to go back and look at it. It may be an older version, but it's posted.